Welcome you all in the part 2 of cardiac arrhythmia and its treatment. In the part 1 you have seen what the arrhythmia is and the types of cardiac arrhythmia and the mechanism how it happens. In the part 2 we will discuss about the antiarrhythmic drugs, their classification, their pharmacological actions and mechanisms. So here if you see this table, there is a classification of the drugs given, and unlikely to the other chapters, here the classification is little differently given. Its antiarrhythmic classes have been divided like 1A, 1B, then 1C, and they are having the subclasses. So we'll move one by one. We'll see the first one is the class 1A. So where we have the quinidine, procainamide, disopyramide, morsazine, and ahead of these drugs we have a slight indication of the mechanisms what these drugs are following. So if you see that in front of the class 1A, it's written like decreases the Vmax of phase 0. So already I have explained you the various phases of the cardiac action potential generation. So you can understand by this that if the rate of phase 0 decreases, then what happens? The the velocity of action potential generation goes down. So in that case, it increases the refractory period and moderately decreases the conduction velocity, decreases fast inward sodium current, inhibit potassium repolarization current. So later we will, in the coming slides, we will discuss in detail what the mechanism they possess. Now the second class, that is class 1B, here we have some local anesthetics, lidocaine, we have phenytoin, already have seen the phenytoin in the chapter CNS, tocinide, morisazine and mexiletine. Here also you can see the minimal changes you can observe in the Vmax of phase 0 as well, and decreases cardiac action potential duration, decreases inward sodium current in ventricular muscle, increases outward potassium current. So like almost similar mechanism it has. Now we can move it to 1C. 1C, it also has this subclass that 1C2. It also has 1C2, 3 and 4. So first 1C has flecainide and propafenone. Second have propranolol, metoprolol. You know these beta blockers you already have seen before. So these drugs are coming in because the treatment for arrhythmia is not only to treat that particular cause why what it happened, but also the associative symptoms and the causes need to be controlled. So that's what the classification all these drugs are coming in. Propranolol, metoprolol, nedolol, acebutol, atenolol, pindolol, timolol, sotalol, ismolol, right? And the mechanisms are given here, like the beta adrenoceptor antagonist, you know very well. Cardiac membrane stabilization, what they do cardiac membrane stabilization. You remember that the classification of the beta blockers there, one membrane stabilizing activity, so they also do that. Indirect effect on sinoatrial node of decreased rate of spontaneous diastolic depolarization. So what they are doing, they are decreasing the rate of diastolic depolarization. Indirectly, they also affect on the AV node of decreased conduction velocity and prolonged ERP. Third one, amiodarone, very important drug, very much used drug in case of arrhythmia. Amiodarone, Britaglium and sotalol. Fourth one is abutilide, dofetilide, verapamil, deltiazem and bipyridine. So here we have the calcium channel blockers as well coming under this category. So now we'll move on with the class 1 drugs. Here I have given a very small account of each class. So by seeing this, you can understand the brief information about the mechanisms of these class of drugs. So what will happen when you will remember that this particular drug belongs to that particular class, this summary will help you out to write the mechanism and other details. So you can see here the class 1 antiarrhythmic drugs are characterized by their ability to block the voltage gated sodium channel. So what the mechanism they are following? They are actually blocking the voltage gated sodium channel, and they also do one thing, they block the gated sodium channel, voltage gated sodium channel in two conditions, either when they are what called the open state or when they are inactivated state. You know very well that these channels are present in three different states: open state, closed state, and the inactivated state. So here these drugs are acting on these two particular states. Inhibition of the sodium channel results in a decrease in the rate of rise of phase 0 of the cardiac membrane action potential. So you know, again go back to that diagram where the all phases have been explained and the generation of action potential. So you can understand very well that when the sodium channel opens and sodium starts coming in, then actually the depolarization starts, and then depolarization carried forward when the more sodium channels are getting open. Now here what is happening, the sodium channels are decreasing. So when sodium channels are less, then the rise of phase 0 will be slower. So this way, when it is slowing the generation of action potential, so of course the conduction velocity will also be decreased. The antiarrhythmic drugs in class 1 suppress both normal Purkinje fiber and His bundle automaticity. So now they are acting on the automaticity of the Purkinje fibers as well as the bundle of His, in addition to abnormal automaticity resulting from myocardial damage. So one automaticity already disturbed because of the myocardial damage, but they bring it in a different way. Suppression of abnormal automaticity permits the sinoatrial node again to assume the role of the dominant pacemaker. So what will happen? The abnormal automaticity suppresses. Then what will happen? The SA node again will get the leading role. Okay, so here abnormal automaticity is indicated when other than SA node some other parts are started producing the signal or impulses. So in that case the rhythm get disturbed. So that is what our purpose to control that. The antiarrhythmic agents that belongs to class 1 are divided into 3 subgroups with slightly different properties. So what are these classes under the class 1? Class 1A. So what they do? These drugs slow the rate of rise of phase 0 of the action potential and prolong the ventricular effective refractory period. Okay. Already I have told you there. Members of this class impair the function of the membrane sodium channel, thereby decreasing the number of channels available for membrane depolarization. Okay, it's very well clear. Class 1A drugs do not alter the resting membrane potential but slow conduction velocity. So here little more clear information is given that these drugs are not changing the resting membrane potential, right? But they slow down the conduction velocity. Members of this class directly decreases the slope of phase 4 depolarization in pacemaker cells. Right, so that is the reason this point is directly indicating the slowing down, or what called the increasing the refractory period. Okay. Now we move to the class 1B, have a minimal effect on the rate of depolarization and are characterized by their ability to decrease the duration of action potential and ERP of Purkinje fibers. So you see, they are not changing much the rate of depolarization, while what they are doing, they decrease the duration of action potential, means how long the action potential exists or persists. That is the action of these class 1B drugs. So they are decreasing that one. Members of this class have a minimal effect on conduction velocity in ventricular myocardium and are without apparent effect on refractoriness. So they are not changing the conduction velocity also, and also not affecting much the refractoriness. Now move to the class 2 drugs. Class 2 antiarrhythmic drugs competitively inhibit beta adrenoceptors and inhibit catecholamine induced stimulation of cardiac beta receptors. In the last class, in the last video, I have discussed you about the what called the stimulation of the cardiac heartbeat because of the intervention of the norepinephrine. So here those norepinephrine, when binds with the beta 1 receptor, they stimulate the beta 1, they stimulate the cardiac rhythm. So they can go for the tachyarrhythmic condition. So here these drugs are going to inhibit that particular point. In addition, some members of this group, example propranolol and acebutol, causes electrophysiological alterations in Purkinje fibers and resemble those produced by class 1 antiarrhythmic drugs. So some drugs, right, are having some effect on the electrophysiology of the Purkinje fibers as well, what you have seen in the class 1 drugs. Okay, but main effect is by blocking the stimulation by beta receptors. The later action have been called membrane stabilizing effects. So the second one, what you have seen, that they also have the electrophysiological alteration, that what you have classified in the beta blockers with membrane stabilizing action. So here these drugs are having this membrane stabilizing activity. Now we'll move to the class 3 drugs. Class 3 antiarrhythmic drugs prolong the membrane action potential by delaying repolarization. So now third type of mechanism, you can see what these drugs are doing. Here they are delaying the repolarization. Okay, so what will happen if repolarization delays, and then the next cycle of action potential generation will be delayed, right? So the conduction will also be delayed. Without altering phase 0 of the depolarization of the resting membrane potential. Unlikely the class 1 drugs, they are not at all changing the phase 0 rate of the phase 0 depolarization. Class 3 drugs have a significant risk of proarrhythmia because of the prolongation of action potential and the induction of torsidy pointase. So we have discussed this point before in the previous video. And here, because it is prolonging the action potential, because it is delaying the repolarization, means prolonging the action potential. You have seen that plateau phase has been observed, so maybe that is a little continued for more time. So that also called as the proarrhythmic condition, but it's not actually the arrhythmia what we are talking about as a disease, but it may happen for a while. So this is the class 3 drugs, and I think in the previous video I thought I'll take you up to here, so I put the thank you slide here. So no problem, we'll skip and move further. We'll go to the class 4 drugs. Class 4 drugs block the slow inward calcium current, L-type calcium channel in cardiac tissue. Now entirely different class 4 drugs, as I have told you, there you have seen deltiazem and nifedipine. So these are the potential calcium channel blockers. So that's why these drugs are acting on calcium blocking here. So what they are doing, they block the slow inward calcium current, and which especially they are binding with which calcium channel? L-type calcium channel. The administration of class 4 drugs slows conduction velocity. So what they are doing, they are decreasing the conduction velocity and increases refractoriness. So the refractory period will be prolonged in the AV node, thereby reducing the ability of the AV node to conduct rapid impulses to the ventricle, because their all focus is on AV node, and you know very well the AV node receives the impulses from SA node and conduct it further. So here this conduction is going to be affected. This action may terminate supraventricular tachycardias and can slow conduction during atrial flutter or fibrillation. So it would be good. These drugs can be very good in case of the supraventricular tachycardias and the atrial flutter or fibrillations. So this you by this summary you understood that which are the class of drugs, what are their examples, and a summary of their mechanisms, how actually they work. Okay. Now we'll take the individual drugs, and we'll first discuss about the very important drug of this class, quinidine. So quinidine, a diastereomer of the antimalarial quinine, right, which is nowadays very much in discussion as the most potent of the antiarrhythmic substances extracted from the cinchona plant, used as an antiarrhythmic agent. So this is a very close relative of the quinine. Quinidine is used to maintain sinus rhythm in patients with atrial flutter or atrial fibrillation, and to prevent reoccurrence of ventricular tachycardia or ventricular fibrillation. So nothing much to explain about. You already know which class it belongs, and already we've seen that what that class of drugs do. So here you can understand very well that it used for the atrial flutter, atrial fibrillation to control, also in the ventricular tachycardias or ventricular fibrillations. What is pharmacological action of this drug? Quinidine blocks sodium current and multiple cardiac potassium currents. It is an open state blocker of sodium channel. So what is the case? When open state blocker, as I told you, these drugs are having blocking the sodium channel by two ways. Either in one is the like open state, and another in the inactivation, any inactivated sodium channel. So this drug is acting on the open state blocker of sodium channel. At therapeutic concentration, quinidine commonly prolongs the QT interval up to 25%. So here, as a side effect, you can find it has an effect on it changing the ECG and prolonging the QT interval up to 25%, but the effect is highly variable. Quinidine's sodium channel blocking property results in an increased threshold for excitability and decreased automaticity, right? So this way, because it has increased the threshold of excitability, so it decreases the automaticity automatically. As a consequence of its potassium channel blocking action, quinidine prolongs action potential in most cardiac cells, most prominently at slow heart rates. Okay. In some cells, such as mid-myocardial cells and Purkinje cells, quinidine consistently elicits EADs at slow heart rates. You already remember DAD and EADs we have discussed. So it have the potential to control those EADs. Quinidine prolongs refractoriness in most tissues, probably as a result of both prolongation of action potential duration and sodium channel blockage. I hope it's clear this point to you. Now we'll see what it does to SA node and atrial tissues. The indirect effect of quinidine on the sinoatrial node is a result of the drug's potential to exert an anticholinergic action, resulting in a slight increase in heart rate. So here it has an anticholinergic effect, right? Means you can say a kind of atropinic effect, which you can observe here. So here you can see a little slight increase in the heart rate is there. Higher concentration of quinidine have a direct effect of depressing the rate of spontaneous diastolic depolarization. So it's a dose dependent effect. once you give the higher doses, it directly affects the by depressing the rate of diastolic depolarization. Quinidine administration results in a dose-dependent depression of membrane responsiveness in atrial muscle and fibers. That's what I told you. The maximum rate of phase 0 depolarization and the amplitude of phase 0 are depressed equally at all membrane potentials. Okay, so it depresses the phase 0. Quinidine also decreases atrial muscle excitability in such a way that a larger current stimulus is needed for initiation of an active response. So atrial muscle excitability is also increasing. Is decreasing. These actions of quinidine often are referred to as its local anesthetic properties. So these particular effects we can say like quinidine has some kind of local anesthetic property, what it does to produce this particular effect. What it does on AV node, both the direct and indirect actions of quinidine are important in determining its ultimate effect on AV conduction. The indirect, which is called anticholinergic properties of quinidine, prevent both vagally mediated prolongation of the AV node refractory period and depression of conduction velocity. So here you can see because it has some anticholinergic properties. So because of that, what it does, it prevents vagus impulses. So it the what called the discharge of the vagal nerve, it get controlled by this, right? So vagally mediated prolongation, earlier what the prolongation comes through vagus, that can be controlled of the AV node refractory period and depression of conduction velocity. So the depression of conduction velocity is also been prevented. So these are like little different effect than the normally does. So what's doing on the ventricular region, what is doing on the bundle of hairs, or what is doing on the other electrical fibers, on the AV node it does little different. Quinidine's direct electrophysiological actions on the AV node are to decrease conduction velocity and increase the ERP. Okay. So dose dependent effects on AV node is there. His Purkinje system and ventricular muscle. What it does there? Quinidine can depress the automaticity of ventricular pacemaker by depressing the slope of phase 4 depolarization. I hope this point is very clear. We have already discussed about. Depression of pacemaker in his Purkinje system is more pronounced than depression of sinoatrial node pacemaker cells. That this is the point what I have discussed in the previous slide as well, that depression of pacemakers in the his Purkinje system is more pronounced than depression of sinoatrial node pacemaker cells. So in the his Purkinje system it is more effective compared to SA node. Quinidine also prolongs repolarization in Purkinje fibers and ventricular muscle, increasing the duration of the action potential. So what it does, it prolongs the repolarization. So the new cycle delays and the refractive period prolongs. So like that, increasing the duration of the action potential. As an atrial muscle, quinidine administration results in post repolarization refractoriness, that is an extension of refractoriness beyond the recovery of the resting membrane potential. This is a little different point here. So what is happening, an extension of refractoriness beyond the recovery of the resting membrane potential has been also observed. Serum potassium concentration have a major influence on the activity of quinidine on cardiac tissues. So that has a great role, what the concentration of potassium ions are there. Low extracellular potassium concentration antagonize the depressant effect of quinidine. Now you see, low extracellular potassium concentration. If outside of the cell the concentration of potassium is low, then this is a kind of antagonistic effect will be produced. So it antagonizes the depressant effect of quinidine on membrane responsiveness. Now, opposite of it, if the high extracellular potassium concentration there, then it increases the quinidine's ability to depress membrane responsiveness, because ultimately it is going to act on the ion channels there. This dependency may explain why hypokalemic patients are often unresponsive to the antiarrhythmic effect of quinidine and are prone to develop cardiac rhythm disorders. I don't know you have seen any cardiac patients admitted in the hospital on regular routine or not. If you observe the few days to the patient there, you can find they quite frequently the clinicians are checking the electrolyte level for the cardiac patients. This is the reason, because the level of these ions in the body determines the treatment what they are planning to give or what they are giving. So the effect of that, the effectiveness of the treatment belongs to that comparison of the availability of ions. Now, electrocardiographic changes, there are some ECG changes also been there. At normal therapeutic plasma concentrations, quinidine prolongs the PR, the QRS and the QT intervals, right? So this thing you can write later into the side effects as well. QRS and QT prolongations are more pronounced with the quinidine than with most other antiarrhythmic agents. So, but another aspect of it is that because it is when arrhythmia condition comes, then also you have seen in the previous video I have shown you the various ECGs. So that ECGs are changing. So here by the effect of this drug on ECG, maybe it get regularized and it comes to the normal. The magnitude of these changes is related directly to the plasma quinidine concentration. So these are the actions of the quinidine. Now we'll see clinical uses. Primary indications are abolition of premature complexes that have an atrial, AV junctional or ventricular origin. Right. Second is restoration of normal sinus rhythm, because ultimately if you want the heart back into the normal, heart must show the normal rhythm. For that, SA node has to take all the charge. So restoration of normal sinus rhythm in atrial flutter and atrial fibrillation after controlling the ventricular rate with digitalis. Okay, so this is the combination treatment can be given and control. Maintenance of normal sinus rhythm after electrical conversion of atrial arrhythmias. Prophylaxis against arrhythmias associated with electrical counter shock. So here for electrical counter shock cases, also prophylactically we can use. Termination of ventricular tachycardia. So for this purpose we can use. Suppression of repetitive tachycardia associated with Wolff-Parkinson-White syndrome, already discussed before. Its administration in the presence of a rapid atrial rate, which is a flutter and possibly atrial fibrillation, can lead to a further and dangerous increase in the ventricular rate secondary to inhibition of basal vagal tone upon the AV node. What does it mean? Its administration in the presence of a rapid atrial rate. So when the flutter and possibly atrial fibrillation is present, and that time itself the quinidine is given, then because of changing in the vagal tone, it may dangerously increase the ventricular rate. For this reason, digitalis should be used before quinidine when one is attempting to convert atrial flutter or atrial fibrillation to normal sinus rhythm. Now we see the ADRs. The most common adverse effects are diarrhea, upper GI tract distress, and lightheadedness. Others include fatigue, palpitations, headache, angina-like pain, and rashes. In some patients, thrombocytopenia due to the formation of a plasma protein quinidine complex that evokes a circulating antibody directed against the blood platelet. The cardiac toxicity of quinidine includes AV and intraventricular block. So, what quinidine is producing the cardiac toxicity? AV and intraventricular block, ventricular tachyarrhythmias, and depression of myocardial contractility. Ventricular arrhythmia induced by quinidine leading to a loss of consciousness has been referred to as quinidine syncope. Very important word, quinidine syncope. The devastating side effect is more common in women than in men and may occur at therapeutic or subtherapeutic plasma concentrations. Large dose of quinine can produce a syndrome known as synchronism, which is characterized by ringing in the ears, headache, nausea, visual disturbances or blurred vision, disturbed auditory acuity, and vertigo. Larger dose can produce confusion, delirium, hallucinations, or psychosis. Quinidine can decrease blood glucose concentrations, possibly by inducing insulin secretion. So, here also is a very important point, quinidine's effect on insulin secretion, right. So, because this effect can be very much been discussed when the patient is arrhythmic and diabetic. Drug interaction, quinidine can increase the plasma concentrations of digoxin, which may in turn lead to signs and symptoms of digitalis toxicity. GI effects, central nervous system or cardiac toxicity associated with elevated digoxin concentration may occur. So, this is a very important potential interaction between the digoxin and quinidine, both used for the same purpose. And so, you have to see when you are using together and what is the consequences. Quinidine and digoxin can be administered concurrently. However, a downward adjustment in the digoxin dose may be required. So, what the third point makes your doubt clear that we can use them, but when we use them, digoxin dose we should we should temper the dose to the lower side. Drugs that have been associated with elevations in quinidine concentrations include, means now I'm going to tell you those drugs which are elevating the quinidine concentration: acetazolamide, the antacids, magnesium hydroxide and calcium carbonate, also H2 receptor antagonist cimetidine. Cimetidine inhibits the hepatic metabolism of quinidine. What cimetidine does? Cimetidine inhibiting the hepatic metabolism of quinidine. Also, phenidine, rifampin and barbiturates increases the hepatic metabolism of quinidine and reduces its plasma concentration. So, you know very well what happens when the hepatic metabolism increases. Okay. So, by this I hope you understood what the quinidine does. Now, we will see the class 1B lidocaine, and some drugs I will not take the entire detail because already have studied in some other chapters. Lidocaine was introduced as a local anesthetic and is still used extensively for that purpose. Lidocaine is an effective sodium channel blocker binding to channels in the inactivated state. If you remember the chapter local anesthetics, you may know what lidocaine does and how it does. Lidocaine, like other 1B agents, acts preferentially in diseased tissues, causing conduction block and interrupting reentrant tachycardias. What it does on SA node, when administered in normal therapeutic doses, lidocaine has no effect on the sinus rate. Atrium, the electrophysiological properties of lidocaine in atrial muscle resembles those produced by quinidine. So it has some quinidine-like effect on the atrial muscles. Membrane responsiveness, action potential amplitude, and atrial muscle excitability are all decreased, right? So these all things get decreased. These changes results in decrease in conduction velocity as well. However, the depression of conduction velocity is less marked than that caused by quinidine or procainamide. Action potential duration of atrial muscle fiber is not altered by lidocaine. So you see action potential duration is not been altered, right? At either normal or subnormal extracellular potassium level. So irrespective of the potassium level, it doesn't alter the duration of the action potential. The ERP of atrial myocardial cardium either remains the same or increase slightly after the lidocaine administration. AV node, lidocaine minimally affects both the conduction velocity and the ERP of the AV node, right? So you have seen most of the drugs are having a different kind of effect on SA node and slightly different effect on AV node. Lidocaine does not possess anticholinergic properties and will not improve AV transmission when atrial flutter or atrial fibrillation is present. This is the case we discussed in the case of quinidine. His Purkinje system and ventricular muscle lidocaine reduces action potential amplitude and membrane responsiveness. Significant shortening of the action potential duration and ERP occurs at lower concentration of lidocaine in Purkinje fibers than in ventricular muscles. Lidocaine is very low concentration, slows phase 4 depolarization in Purkinje fibers and decreases their spontaneous rate of discharge. Okay, so in the low doses, it also has this dose dependent effect on the Purkinje fibers and also slows down the phase 4 depolarization. In higher concentrations, automaticity may be suppressed and phase 4 depolarization eliminated. Okay, so this is a difference between the higher and lower concentrations. Electrocardiographic changes, what the ECG changes it brings. Lidocaine does not usually change the PR, QRS or QT interval, what you have seen in quinidine, although the QT may be shortened in some patients. The paucity of electrocardiographic changes reflects lidocaine's lack of effect on healthy myocardium and conducting tissues. Hemodynamic effects, lidocaine does not depress myocardial functions even in the face of congestive heart failure at usual doses. So what is the clinical uses for the lidocaine? Here, lidocaine is useful in the control of ventricular arrhythmias, particularly in patients with cause myocardial infarction. Lidocaine is the drug of choice for treatment of the electrical manifestation of digitalis intoxication. So when digitalis get intoxicated and it changes drastically the electrophysiological conditions, lidocaine can act to treat those conditions. Adverse effects, the most common toxic reaction as seen after lidocaine administration affects the CNS. Drowsiness is common, but unless excessive may not be particularly undesirable in patients with acute myocardial infarction. Some patients have paresthesias, disorientation, and muscle twitching that may forewarn of more serious deleterious effects, including psychosis, respiratory depression, and seizures. Lidocaine may produce clinically significant hypotension, but this is exceedingly uncommon in the drug is given in moderate doses. So that hypotension won't be producing because low doses are being given. Depression of an already damaged myocardium may result from large doses. So large doses not safe. Contraindications, Hypersensitivity includes the hypersensitivity to local anesthetics of the amide type, a very rare occurrence, amide type. Severe hepatic dysfunction, a history of grand mal seizures due to lidocaine and age 70 or older. So these are some precautions to be taken. Lidocaine is contraindicated in the presence of second or third degree heart block, since it may increase the degree of block and can abolish the idioventricular pacemaker responsible for maintaining the cardiac rhythm. Drug interactions, the concurrent administration of lidocaine with cimetidine but not ranitidine may cause an increase 15% in the plasma concentration of lidocaine. This effect is manifestation of cimetidine reducing the clearance and volume of distribution of lidocaine. So why they are interacting with each other? Which way? The cimetidine reducing the clearance and volume of distribution of lidocaine, right? So it's a pharmacokinetic kind of drug interaction. The myocardial depressant effect of lidocaine is enhanced by phenytoin administration. Now we'll move to the class 1C, which is the flecainide. So now we'll discuss the class 1C, where I've taken a drug flecainide. Flecainide is a fluorinated aromatic hydrocarbon examined initially for its local anesthetic action and subsequently found to have antiarrhythmic effects. Flecainide inhibits the sodium channel, leading to conduction slowing in all parts of the heart, but most notably in the His-Purkinje system and ventricular myocardium. It has relatively minor effects on repolarization. Flecainide also inhibits abnormal automaticity. So actions on SA node, flecainide decreases the sinus cycle length but results in a clinically insignificant decrease in heart rate, while having some effect but not significant. So atrium, flecainide decreases the maximal rate of repolarization in atrial tissues and shifts the membrane responsiveness curve to the right. AV node, the atrioventricular conduction time measured as the AH interval is prolonged by flecainide, as is the His-Purkinje or HV interval. His-Purkinje system and ventricular muscle. Flecainide slows conduction in the His-Purkinje system and ventricular muscle to greater degree than in the atrium. Okay. So flecainide may also cause block in accessory AV connections, which is the principal mechanism for its effectiveness in treating AV reentrant tachycardia. Electrocardiographic changes. So here also it increases the PR, QRS and lesser extent to QTC interval. Uses, flecainide is effective in treating most types of atrial arrhythmias. It is also used in life-threatening ventricular arrhythmias. It must be used with cautious at any patient with structural heart disease. Flecainide crosses the placenta with the fetal level reaching approximately 70% of the maternal level. In many centers, it is the second line drug after digoxin for therapy of fetal arrhythmias. So this is one of the very good drug. Because of the high incidence of proarrhythmia, initiation of therapy or significant increase in doing should be performed only on initiation, I think. ADR, most adverse effects occur within a few days of initial drug administration. Most frequently are dizziness, lightheadedness, faintness, unsteadiness, visual disturbances, blurred vision, example spots where the eye is difficult in focusing, nausea, headache and dyspnea. Worsening of heart failure and prolongation of the PR-QRS interval are likely to occur with flecainide, and an increased risk of proarrhythmia has been reported. What are the contraindications? Flecainide is contraindicated in patients with pre-existing second or third degree heart block or with bundle branch blocks unless a pacemaker is present to maintain ventricular rhythm. It should not be used in patients with cardiogenic shock. Drug interaction. In patients whose condition has been stabilized by flecainide, the addition of cimetidine may reduce the rate of flecainide's hepatic metabolism, increasing the potential for toxicity. Flecainide may increase digoxin concentrations on concurrent administration. Now we move to class 3. Drug what I have taken is Britaillium. Britaillium was introduced for the treatment of essential hypertension but subsequently was shown to suppress the ventricular fibrillation, often associated with an acute myocardial infarction. So what the Britaillium's actions are? The net effects of Britaillium on the electrical and mechanical properties of the hearts are composite of the direct action on the drug on cardiac tissues and indirect action mediated through the drug's effect on the sympathetic nervous system. So direct and indirect, both kind of effect it produces directly through heart and indirectly through nervous system. What it does on SA node, the Britaillium administration produces an initial brief increase in sinus node automaticity. That is probably the result of a drug-induced release of catecholamines from sympathetic nerve terminals. No change or a slight decrease in sinus heart rate is observed under the initial phase of catecholamine release. Atria at therapeutic concentrations, the only significant effect of Britaillium is to prolong the action potential. The result in prolongation of the ERP of the atrial muscle. AV node, moderate doses increases conduction velocity and decreases the AV node refractory period. This effect may result from the initial drug-induced catecholamine release. The net effect of Britaillium on AV transmission during the chronic therapy is unknown. His Purkinje system, the most prominent electrophysiological action of Britaillium is to raise the intensity of electrical current necessary to induce ventricular fibrillation. This action, which is more prominent with Britaillium than with any other available antiarrhythmic agent, can be observed in both normal and ischemic hearts. Hemodynamic effect, a unique property of Britaillium as an antiarrhythmic agent is its positive inotropic action. This effect relates to its action on the sympathetic nervous system, indicates an initial release of neuronal stores of norepinephrine followed shortly by prolonged period of inhibition of direct or relaxed associated neuronal norepinephrine release. The onset of Britaillium-induced hypertension is delayed 1 to 2 hours because the initial catecholamine release maintains arterial pressure before this time. Britaillium is not to be considered a first line antiarrhythmic agent. However, because of its ability to prolong the refractory period of Purkinje fiber and to elevate the electrical threshold to ventricular fibrillation, Britaillium has been found useful in the treatment of life-threatening ventricular arrhythmias. In addition, Britaillium is known to facilitate the reversal of ventricular fibrillation by precordial electrical shock. This is a very important function of the Britaillium. Its use should be limited to no longer than 5 days. What ADR it has? The most important one is hypertension as a result of peripheral vasodilation caused by adrenergic neuronal blockage. nausea, vomiting, and diarrhea have been reported. Longer-term problems include swelling and tenderness of the parotid gland, particularly at mealtime. Contraindications. The associated initial release of catecholamine may result in an excessive pressure response and stimulation of cardiac force and pacemaker activity. The resulting increase in myocardial oxygen consumption in a patient with ischemic heart disease may lead to ischemic pain. Patients in a state of circulatory shock probably should not be administered Betalium because of its delayed sympatholytic action. Now we see the last class of class 4. We see the drug Verapamil. Verapamil, in addition to its use as an antiarrhythmic agent, has been employed extensively in the management of variant or prismatal angina and effort-induced angina pectoris. It selectively inhibits the voltage-gated calcium channel that is vital for action potential genesis in slow response myocytes such as those found in these SA and AV nodes. What it does on SA node? SA node, spontaneous phase 4 depolarization, a characteristic of normal sinoatrial nodal cells, release on progressive inhibition of an outward potassium current and an increase in a slow inward current that is carried by sodium and potassium ions. Verapamil decreases the rate of rise and slope of the slow diastolic depolarization, the maximal diastolic potential and the membrane potential at the peak of depolarization in the sinoatrial node. What it does on atrium, Verapamil fails to exert any significant electrophysiological effect on the muscle. AV node, Verapamil impairs conduction through the AV mode and prolongs the AV nodal refractory period at plasma concentration that shows no effect in this Purkinje system, his Purkinje system. So now next effect on his Purkinje system and ventricular muscle. The most important electrocardiographic change produced by Verapamil is prolongation of the PR interval, a response consistent with the known effect of the drug on AV nodal transmission. Verapamil has no effect on intra-arterial and intraventricular conduction. The predominant electrophysiological effect is the AV conduction maximal to his bundle. Hemodynamic effects, usual four doses of Verapamil are not associated with marked alterations in arterial blood pressure, peripheral vascular resistance, heart rate, left ventricular end-diastolic pressure or contractility. What is the clinical use for the Verapamil? Is useful for conditions like tachyarrhythmias, atrial tachyarrhythmias, ventricular responses to atrial tachyarrhythmias such as atrial flutter and fibrillation. It is also effective for enhancing the automaticity and such as ectopic arterial tachycardia and idiopathic left ventricular tachycardia. So all of these conditions Verapamil is useful. Adverse effects, orally administered Verapamil is well tolerated by most patients. Most complaints are of constipation and gastric discomfort. Other complaints include vertigo, headache, nervousness and pruritus. Contraindications. Verapamil must be used in the extreme caution, so not in all the patients who are receiving beta receptor blocking agents. Normally, the negative chronotropic effect of Verapamil will in part be overcome by an increase in the reflex sympathetic tone. So by this we are finishing off all the important drugs of this classification. The rest of the individual drugs you can cover it by yourself. Now here we have the assignment. These drugs you have to complete with the pharmacology of each of these drugs. Okay. These are the references used for this purpose.